to this meeting, which is out of sync, for which we apologise. Normally, this wouldn't be a formal meeting of the board, but we wanted to consider the response to the consultation in Sheffield. So that's it's a single agenda item, and that's what we're here to do. So welcome everybody. I've had apologies for absence from Kieran Baker, who's not well, and from Lucy Davis, who's also not well. But Laura, I can see you on screen. You're very welcome. Lovely to see you. Lucy suggested that Laura join us from Health Watch Sheffield. We'd rather, particularly given the agenda item, we thought it was helpful to have Laura here. So welcome, and please put your hand up if you want to speak, Laura. You'd be very welcome. Nice to see you. Okay, declaration of interests. I'll take silence to be none. Minutes of the meeting the 4th of Jan, are they okay? Thank you very much. Is there anything arising from the action log that I need to need to pick up? I think most of them on the agenda are clearly an integrated care strategy. That's a red, and I'm kind of looking slightly.
It's for the anything that's on here on the whole is for the March meeting.
It's for the March meeting. Okay, thank you. Thanks, Will. Sorry. Okay, questions from the public. We've received questions around the consultation in Sheffield, which we're coming on to. So what I think we're going to do is we're going to do the presentation on Sheffield, have the discussion, and then I'm going to ask whether we think we've kind of answered all the questions. Most of them are about what I would describe as the process of consultation, and rather go through the substantive and see whether we think we've answered them all. We have got written response as well, but I think it's about the substance of this. So some of this will be not just the outcome of the consultation, but actually the process of the consultation, if that's okay. So we'll deal with that under the substantive item, which we can move on to, which is the business case for primary care capital. Am I handing over to you, Emma?
You are. Thank you, Chair. Okay, morning everybody. Just before I start, I just want to introduce my two colleagues who you may know or you may not know. So Jackie, do you want to introduce that?
Yeah, I'm Jackie Mills. I'm Chief Finance Officer for Sheffield, and I've been the lead for this programme.
Hi, I'm Lucy Etcher, Deputy Director of Community Development, and I was the Comms Engagement.
Welcome, Emma.
So good morning. Thanks to everybody. I hope you've managed to read the 400 old paper.
Can I confess something, Emma?
So if you haven't, what we're trying to do is summarise some of the key points in the presentation this morning, which will be done by us all. We'll all have to speak for that. So before I start, obviously this started in 2018, so when the CCG was in place. So we've been through quite a lengthy process, and we'll outline that today. And obviously we're sort of this is probably the first one in terms of transition to an ICS. Yes. But as you know, ICSs are designed to bring together different health and social care organisations to work together to improve the health outcomes for our population. And I think flexible estate supports multidisciplinary working, easy access, standard clinical rooms, interactive waiting spaces that promote good health and are energy efficient, which contribute to the net zero position, are really important. I think, in terms of context and really to the fore ends of the ICS, I think as we go through this, you'll see how we're going to do that. Okay, so second slide, please. Thank you. Okay, so just in terms of context and timescale, so this started in 2018 when GP practices in Sheffield started developing bids. In 2020, Sheffield CCG developed a strategic outline case, and in March 2022, South Yorkshire and Bassett Raw Treasury funding was confirmed, including 37 million for the Sheffield part, which was up to 5 new health centres in Sheffield. In March to May, we started engaging with the public and stakeholders. In May to July, we started drafting the proposal to reflect the first part of our engagement. And in August to October 22, we started the formal consultation with the public and stakeholders. In November to December 2022, we considered the recommendations, and today we're presenting the findings to you. Okay, so that's just setting the context. So there were 5 centres proposed initially. Up till July 2022, 15 practices were part of this programme to move to a new facility. Proposals were for 1 in the city centre, 2 in Shire Green, Firth Park, Southie Green and Parsons Cross area, and 2 in the Burgreave, Pixmore, Fairvale and Pagehall area. So for those of you who don't know Sheffield very well, and I'm conscious I haven't been here for 6 months, there's the map. And you'll see where the circle is in the northeast of Sheffield. We go on just on to the next slide, please, Mark. You'll see that that really is where most of our health inequality lies. So actually, this resource, this estate, will be targeting one of our most deprived areas in the northeast of Sheffield. And in terms of the case for change, obviously you'd expect us to be tackling those wide health inequalities in the northeast of Sheffield. The average age of the estate, we've got some pictures if anyone wants to see them later on of some of the buildings, but they are over 50 years old and they're not really relevant for modern treatment of health and care. Obviously, there'll be an impact on primary care to recruit and retain staff if we can't have modern fit for purpose buildings. I think we'll provide a key to those communities in terms of supporting communities with complementary services that already exist. How do we build on that? And I think there's limited opportunities really for bringing the community in, PRs, roles, and also integration. Our sole purpose really is integration, vertical integration at the point of delivery. And what these services we do is provide us with opportunity. Okay. So some other benefits, we'll be able to benefit from additional hours roles. We'll have obviously multidisciplinary services on site, keeping people fit and well and out of hospital. The new health centre will hopefully attract more partners, more primary care workforce and other community assets. We may attract new GP partners as a result of that, or new GPs. The savings are likely to be 140k a year in terms of running costs and efficiencies. And we think more than 50,000 patients can benefit from the development. And we'll be able to help protect the future of general practice in the north east of Sheffield, which is really important to us. Okay, so I'm just going to hand over to Jackie now. Thank you.
Thank you. So I'm just going to take you through a summary of the proposals that we consulted on. So this table shows you the four proposals that we formally consulted on. There is a fifth that's in the programme at the city centre. Because we haven't located a site at the point in which we wanted to go out to consultation, we didn't formally consult on that. But you'll see it is referenced in the decision-making business case that we still intend to continue with that, and we will do relevant consultation at the point in which we've identified the site. So we've got four potential sites that we consulted on. So the Foundry one, that is initially it's small surgery. When we did the pre-engagement, we're interested in exploring whether they would move. The initial feedback they got was actually they decided that they wanted to stay where they were. So in the consultation, we moved forward with Burn-Grieve surgery and Sheffield Medical Centre. Burn-Grieve has two branch sites, so Herries Road and Cornerstone. The Cornerstone building is actually opposite on the opposite side of the road to their main site, but the Herries Road surgery is a distance away. And the thing I would say is because of the area that we're looking at, we had real challenges in terms of actually identifying sites. It's a really built-up area. There's very little space to actually build new buildings on. So we were quite limited in actually identifying sites, and that was one of the factors that in the pre-engagement practices would decide whether the sites that we could identify were suitable for them. So the site for the first potential hub at Foundry 1 is Spittle Street. That's immediately adjacent to the current Sheffield Medical Centre, and it is just slightly up the hill from Burn-Grieve's main site. The Foundry 2, it was initially intended that Page Hall and Upwell Street would look to relocate, and that was the option that we consulted on. The site that we identified for that hub is pretty much equidistant between those two practices, so it's in the middle, in a hub right in the middle of the vale. Sapper 1, this was initially one of our largest sites, and actually it was the one that we had the most difficulty in finding a suitable site. So the sites that we could identify were towards the edge of the SAPA network. Oh, I should say SAPA because it's an acronym. It stands for Souther Green and Parson Cross Association. So obviously very familiar to us, but for those who don't know that, I should explain. So initially, Barnsley Road Surgery, Norwood Medical Centre, Elm Lane and Dunwick Road were all looking at potentially relocating, but the site that we could identify at Concord, they felt was too far away for them, so they didn't proceed forward in the consultation. Park and Shiny Green were interested in looking at the option to relocate to Concord. Concord is a leisure facility that's run by the council. It does have other facilities such as our musculoskeletal services run by SDH there, and it is an area that the local authority are looking to redevelop as well. And Melrose Surgery is a branch site of Shire Green Medical Centre. Under that proposal, that would be okay. And then the final site, Saudi Green Medical Centre, determined that after the pre-consultation engagement that they would move, but the other key surgeries, the healthcare surgery, Buchanan Road, and Margetson. I should say Margetson is a branch site of the Ecclesfield group practice. But they're looking to relocate into a site at Buchanan Road and Wordsworth Avenue, which again is a centre in that community. So it's opposite a big Asda. It's next to a community hub that's already there. They're the proposals that we consulted on. In terms of our proposals around what could be provided at the new centres, obviously at the core of this is our general practices. But we were looking to develop opportunities to integrate and co-locate other services, which would mean that some services that people have to travel quite a distance for in these areas could actually be accessed locally. And it was our GP practices working with their communities that have been looking about the areas that they think could really benefit. So we've listed there a range of options. It's important to say that they are still options. We haven't determined the service model, but one of the things that we did ask when we went out to the consultation is what was important to people, what was important to the communities, what was missing in those communities. So a lot of the intelligence that we gathered through that we will use at the next stage in terms of design. So it's important to say what would stay the same, and this has been really important in terms of engaging with our public. So we've been really clear that people will have the choice to stay registered at the same practice. Equally, they have the choice to re-register with another practice if they don't want to relocate. We've looked at the access in these areas and are clear that there are options for patients. But I think people will recognise the continuity of care and people have loyalty to their practices, and they were really keen to understand that they wouldn't be forced to move if they didn't want to. Again, practices were really keen to understand that practices would their brand, the practice that they're used to would stay as an individual practices. Practices are not being asked to merge, and actually practices are not proposing that they merge. It's about they can see benefits of co-locating and learning and sharing, but it's important to them to keep their own identity as well. And as part of that, continuity of being able to see the same doctor, the nurses, the reception staff and the other staff that people see now was really important, and we heard that quite loudly when we did the consultation. People will continue to access face-to-face, telephone and online appointments as now. And you'll appreciate that during this time, things have been changing. So obviously, post-pandemic, there was a lot of telephone and online access. Practices have been moving back into doing more face-to-face. And it was one of the things that our practices, when they were out talking to the patients, were keen to understand. So, you know, it gave them intelligence about what's important. And it's also important to note that we're not proposing that the core hours of the GP services would change. The core contract remains the same, and practices will continue to deliver that. But sorry, Mark, to go to the next one. In terms of what might be different, clearly location. So we're proposing that the location could change. So that could be for some people travel, and travel's been quite an important part of that, so we'll come on to that in more detail in a moment. But it could be nearer, as I said, to access other services that could co-locate. In each of the proposals, at least 2 or more practices would be together under one roof. More staff and more services could be available. So people will be aware that nationally there's the scheme to increase the number of additional roles in primary care. So these primary care networks have been looking to recruit additional staff, but one of the challenges they've told us is actually getting those staff physically located in practice has been difficult. A lot of staff have had to work virtually from home or just camp out in different rooms and move around, and that's had a real impact on either attracting staff to come and work in these areas, but also retaining staff because they've had less valuable experience of actually working in primary care. We're hoping it would be easier to access buildings and have improved facilities. So certainly a number of our practices that are in old converted houses, their disability access is quite challenging. And these new modern buildings will obviously be level access, access to lifts and the like. There will also be modern changing facilities, so access for not just baby changing, but obviously increasingly we have adults that require changing facilities as well, so they would be available. We're looking to use these buildings really effectively and efficiently, so wrapping around services, so the opening hours of the buildings, not necessarily the GP services, could be longer. There will be plenty of parking spaces, and if we come on and look at some of the existing practices, parking is a real challenge for these practices, on-street parking or even no on-street parking in some of the areas. But we should also note that this area is an area that has quite low car ownership as well. So actually, it's potentially not one of the most important things to some people in this. So it's also about access as well. And we're planning that the practices will lease the buildings from the council. So we've been working with Sheffield City Council as our delivery partner to deliver this, rather than practices owning their own buildings or renting from private landlords. I think ownership of practices has been a real issue, particularly in this area. So in some areas, it might be attractive for GPs to buy in because of opportunities for the value that that asset brings. In some of these areas with negative equity, actually being asked to buy into a building is a real barrier to joining the practice. And we heard really strongly from a number of our GPs working in these areas about why they've not bought in, and some of the existing partners, the challenges of trying to retire when they can't get anyone to take over their share. Mark. So, as I said, one of the key things that we got lots of feedback was concerns about how far people might have to travel if their existing practice relocated. So what we did, and you'll see in both in the cover report and in the decision-making business case, we did a significant amount of analysis, not just about how far the proposed locations were from the existing surgeries, but looking at where people live that were registered with these practices. And you'll see from some of the maps in there that actually currently people don't live right next door to their existing practices. They live quite a significant way away from that. And just talk to how loyal people are to general practice as well. So even if people move away slightly, they often continue to use the same general practice. So this table just takes you through how far, on average, from where people currently live to their existing practice, and then where they live to the proposed new site, what the difference is. And you'll see by different hub the distances there. So we did it both in terms of walking distance, actual distance, distance in walking time. People will be aware that things like Google, you can look at this and it doesn't just say, a straight line, how long does it take to walk? It takes into account the topography. And people that know Sheffield, it's quite often it's not flat, so it does take into account if people would have to walk up or down hills. So I don't intend to take you through that, but just to show that we did quite a significant amount of work just in terms of trying to understand that. And as I said, this is an area that has relatively low car ownership compared to other parts of the city. So bus routes was one of the key things that we looked at. because one of the proposed sites was Sapper One at Concord Sports Centre had no direct buses. We had discussed with the combined mayoral authority in South Yorkshire about what the opportunities were to redirect existing buses, and that's not to say put on brand new routes, but were there opportunities to divert existing routes. Buses in South Yorkshire are clearly a challenge in terms of changing routes. That impacts not just on the proposed new locations, but existing sites as well. So we are continuing to engage with the combined mayoral authority on this. But we've set out there for the proposed locations where the new bus routes are and where they're served. So at Foundry 1 at Spittle Street, so there is a bus stop about 200 metres away from the surgery, from Sheffield Medical Centre and the pub. It is fair to say that that is at the bottom of the hill, so just because it's near doesn't mean that it's easy for certain parts of our population to access that. So that is a consideration. At Rushby Street for Foundry 2, that is, there is a bus stop pretty much immediately outside the proposed location, and the same for Stafford 2 as well at Town Road and Elizabeth Avenue. But as I said, Sapper 1 at Concord Sports Centre currently has no direct bus, although there is a bus stop too far away. So I'll just pass over quickly to Lucy just around the consultation findings.
Thanks, Jackie. So the papers do set out the methodology, and hopefully you appreciate that actually we actually tried lots of different methods to reach different parts of the community. So we commissioned an independent research organisation to get us the quantitative data, to get us a robust sample size, and we funded 17 voluntary community sector organisations in the city to get to those marginalised communities. I would say it's the most deprived parts of the city. In terms of how robust the data was, in the paper it talks about it's plus or minus 3% for margin of error, which is really, really robust. And looking at other consultations, so the Consultation Institute, which is sort of the guru on consultations, say that any consultations with a response rate of over 1% is deemed as good. The UK average is 0.7%, and depending on which hub, it was 5 to 10% response rate in Sheffield. And actually, we're confident that every affected patient got communications from their practice. And also, we did have lots of translated materials as well. So we use multi-methods and including public meetings, but this slide summarises the quantitative findings. So we asked people what the advantages were of the proposals, and you can see here it's a bit different in terms of what the most popular were and actually differences in percentages. So Foundry 1 said the biggest advantage was a better range of services. Foundry 2 at a bigger percentage said modern facilities and equipment. Sapper 1, slightly lower percentage, so just over 20% said more appointments will be available. And Sapper 2, the main advantage said was modern facilities and equipment. And looking at the disadvantages, so we asked people as well what disadvantages there were to the proposals. So the main ones for Foundry 1 and Sapper 1 were further to travel away to. As Jackie said, actually, they are a lot further away from current sites, but particularly Sapper 1, so that was nearly 40% of people. Foundry 2, people thought it would be too busy because two practices coming together. I think a lot of people assumed that receptionists would join. And for Sapper 2, actually, they were being really empathetic and worrying about the impact it would have on other people, not necessarily themselves. So a quarter of the samples said the impact it would have on elderly and vulnerable would find it hard to access a new location. We did actually ask the question, which was what most of the equality impact assessment is based on, is then what impact would this have on you, if you have a protected characteristic? And that was about 6 or 8% for people that have protected characteristic. So people were more likely to be worried about other people than people were worried for themselves, if that makes sense. So looking at the positive impact, again, there was a big range here. So the most popular was Foundry 2. So over 3/4 of the people, of the respondents, said they would have a positive impact. And it's down to 33 for Sapper 1 and just over 50 for the other two. The negative impact, a third of people at Sapper 1 said it would have a negative impact and just 17% at Foundry 2. And we asked the question as well that even if the proposal went ahead, actually how likely were you to stay with the practice? And again, there was a bit of a variation here. So Foundry 2 and SAPA 2, so over 80% of people said they'd stay, and that went down to 66% for SAPA 1 and 73% for SAPA 2. And if I can just go through some of the qualitative themes as well, sorry, I haven't done a slide on this. So there was sort of like the big things that came out. So the first one was accessibility and travel. So actually people were worried about being able to get there. You know, as we said, you know, for some people they were further away. The second was changes to current services. So actually people were worried about continuity of care. Would they see the same GPs? Would they be able to make appointments? People, you know, think about there being new telephone number. Actually, if they're competing with another practice, it'll be harder to get through on the phone. The second was appointments and care now. Actually, a big theme that came out is actually people aren't happy with primary care now. You know, there's all sorts of issues with getting routine and urgent appointments. That's a big theme. The fourth is location. And it isn't actually necessarily actually moving the site. It's things like community cohesion, antisocial behaviour. Some of the themes that came out of Foundry 2 were like two very different communities coming together. There's lots of antisocial behaviour near the vocational rights and things. You know, it's a very deprived area. Fifth, parking and traffic. Again, looking at Foundry 2, it's a very congested area and people were worried that people coming into the practice would park on the roads. Hopefully we alleviate some concerns by talking about actually there's going to be about 90 or 100 parking spaces. The sixth is affordability and costs. I think that came up as actually, you know, during the consultation, we're all experiencing cost of living crisis, hyperinflation. Is it affordable? And the seventh was other. And again, that's like impact on other people. And there was one of the things that came through.
Thank you.
Sorry, just in terms of the engagement, I did just want to thank Lucy and the team, and Richard is here on the team as well. I think the community groups were invaluable, particularly about both advising us how to reach harder to reach populations, but also them going and using their networks as well. And I should also acknowledge that Laura and other people from Healthwatch Sheffield were really supportive in to our communities about how they engage with the process and really helping them feedback and encourage that. So I just want to recognise the amount of support that we got in terms of doing that. So I just wanted to go through the recommendations as outlined in the decision-making business case. So we are recommending that 3 of the hubs that we consulted on, that is the Foundry 1 hub at Swift Street, Foundry 2 hub at Rushby Street, and the SAPA 2 hub at Buchanan Road and Wordsworth Avenue, continue to progress forward. So that would be to go to the next stage of design, to go through to the development of a full business case. And I'll go through in a moment what that means. But the proposal is that we would not proceed with the SAPA 1 hub. So you'll see we've set out the reasons in the decision-making business case, but to summarise that this was the lowest ranked scheme when we took a range of factors into account, but the critical ones with this was the low public support. So you'll see from what Lucy just presented that was the one that on evidence and public support. Low stakeholder support. So that's both from councillors and other stakeholders that we heard from, and also the issues about accessibility not currently being on a direct bus route. So whilst we were in conversations with the Combined Mayoral Authority and for exploring that, they couldn't give us any guarantees. And as I said, this is our issue generally. And then so here, in taking all of that into account, here we talked to the practices that were putting the proposals forward. And whilst first part practice did feel that there was still a strong case and mitigations, which I agree reflected that actually, in light of those findings, they probably weren't supported. Clearly, these are persons of interest. They are the main reasons why we've not proceeded with that. So let's talk through the assurance process in terms of what we've been through.
So it's been 2022 was a year of lots of plans and actually lots of data, and it went through a really robust assurance process. And actually some of that obviously started under Sheffield CCG because we started the kind of process in March last year. So development of the plans and all the options went to Sheffield CCG's Primary Care Commissioning Committee, which had delegated authority from the governing body to make decisions around primary care. Went to Sheffield City's Health Scrutiny, so Open Scrutiny Committee. So we took an early idea of the plans, and then we took the plans for pre-consultation engagement. We took the findings from the pre-consultation engagement. We took the plans for consultation. We took consultation. So we've been to scrutiny a lot this year. So actually the plans really have been scrutinised by our local councillors. And also it went to South Yorkshire and Bassett Law Capital Programme Board, which I think is going to continue to have oversight. And also it's part of NHS England's service change and assurance process. And actually, we got the green light from them, and actually they did commend us on the consultation, especially the reach, the breadth and depth of the consultation on the equalities work. The pre-consultation engagement, consultation and quality impact assessments basically went through the same committees, but also went to Sheffield CCG's board committee on engagement and equality, and they had delegated authority from governing body to assure them that we're meeting the legal duties on consultation and engagement. And again, Lisa was actually a member of Speak, and they had lots of reports. And also we involved the Consultation Institute, and they gave us a certificate for consultation readiness. And as I said at the start, they are kind of the gurus in consultation in the UK. They are used by a lot of public sector organisations to keep us safe. And also more recently, the ICB's Quality Performance, Patient Involvement and Experience Committee, which has got responsibility from board for looking at the overseeing of qualities and engagement. There have been lots of good things.
Yes.
Okay.
So go to the next slide. So just wanted to highlight here next steps, because whilst this is quite an important milestone, this just if supported today, if the recommendations are supported, clearly there's still quite a significant amount of work. So if supported, we would look to proceed to the full Treasury business case preparation. So we are following two processes here. So the decision-making business case is part of the NHS England service change process, but we also, as part of receiving funding from Treasury and DHSC, have to demonstrate compliance with Treasury business case as well. We will start phase 3 of the engagement plan. So as Lucy's described, we've heard lots of views from our public around what's important to them, so it's important to carry on with that. So we've heard around from some of our disability groups, and really helpfully at our scrutiny meeting, they came and gave feedback on their engagement today, but also a request that they continue to be involved in the process in terms of design, so that commitment. So that's around both how the building is designed, but it's also about supporting the patients to adjust to the new services. So for visually impaired people, they know how to navigate the route from where they live to their existing practice. They need support to learn a new route. So we gave commitments around that. So there's lots of work around engagement in the next phase. So we're looking to start this fairly immediately, subject to approval of the board. So the design phase will start. The build phase we would look to start November 23 with an expectation that the buildings would be available towards the end of 24. And then obviously there would be a transition phase as practices relocated. As I said, it's about involving people. It's about recognising the different needs of different groups of people. So we've got visually impaired, we've got disabled access, we've got dementia-friendly standards, we've got making buildings. Large buildings can be quite intimidating for people with autistic spectrum disorder. So just thinking about all those issues and working with practices alongside that. And also about keeping people informed. So we're really blessed to get lots of engagement from our populations, from our community groups, and we've learned an awful lot. I think you go into these things thinking that we know a lot of the answers, and quite often we get told that we don't. So we've learned a lot about what's important to our populations, what's important to our communities, and the richness of what's already in our communities. So what we're really careful about, and Emma's been out doing a lot of work with community groups, really keen to make sure that what we do complements what's already there. It doesn't just assume that we need to start from scratch. So there's a significant amount of work we'll do.
Okay, Next slide, last slide. So in summary, I think do nothing is not an option for the majority of the practices we've talked about. I think this is a really positive development for Sheffield and for the ICB. Capital resource is really scarce, unfortunately. And so it's actually quite positive that we've actually received this in South Yorkshire, and it will be invested in those most 5 areas that we talked about in terms of levelling up. I do think it gives us an opportunity to fund some big funds into great care. Primary care is at the heart of what we do. We're talking about neighbourhood development, we're talking about getting alongside our communities. This will give us more access to those communities and allow us to work with them in a different way. We have to build from the bottom up. We have to listen to what our communities are telling us. So I think I just want to say a massive thank you to all the people involved in this. It has been a very in-depth process. I think we've heard today. Obviously, I joined very late to this party, so I can't take any credit for that. It's all down to the team that you see here and the team upstairs in this building. So I just want to say a massive thank you to them. So next question.
That'd be helpful is, Laura, would you, I think it'd be helpful to get a perspective from Health Watch Sheffield before we open up to the board. Are you okay with that?
Yeah, hi everyone, I'm Laura Cook, Policy and Evidence Coordinator for Health Watch Sheffield. I think that the consultation engagement has been very thorough, and we know that a lot of effort has gone into that, and I think that it's important to acknowledge that. But also you can't hear from everybody within that process, and some people, perhaps those that are going to be most negatively impacted by these changes, perhaps didn't have a strong voice within that consultation. So I think it's important to have some ongoing engagement activity with those particular groups. We don't want people that struggle with access already to then find that it's worse for the change in location. I think it's just, yeah, we'd welcome like a review of any sort of further engagement plans as well. We'd be interested to see those. I think it's just about sort of monitoring the risks really, isn't it? And mitigating those risks, and we just need assurance around those.
Okay, thanks, Laura. That's really helpful. Any questions from the board? Thank you, Laura. Lisa.
It's not really a question, it's
Okay.
just a thank you, a big thank you. As Lisa said, I've been looking at these papers for about 9 months now, so I've practically read most of the 400 pages that are in.
I'm impressed, Lisa.
Try to get that. So yeah, it's been a really, really robust process, and it has been scrutinised a lot. And we in SPEAK, the Patient Engagement and Equality team, were really impressed by the lengths that people went to include people in this consultation. And I think it's just, we as a committee, we were assured that that was, you know, we couldn't have done more, basically. So it's just to say thank you for all that work and the time that you put into this. And the investment in primary care is so needed, especially in that community. So it's just great that it's going on the correct way, and we're listening to people. And I'm hoping, and it sounds like it's going to be a dynamic process, and you'll continue to listen as we shape those services going forward.
Thanks, Lisa. Any other points?
Just to follow on that, so but it's a piece of work really well done, this, isn't it? I think the engagement work, the science behind it, and work is so really well done from me. Just to continue on from Lisa's point, this is exactly the work that we should be promoting in primary care. What Emma mentions around neighbourhood integration, work with other agencies, and our different offer of primary care, both access but support in the future. So I really, really support this, and let's use these as a flagship of actually what we want to do across South Yorkshire. So let's do what we say in here and take our public with us. I think I'm really supportive of it.
Chris, and then
So I was involved in this from the very start, 2018. I think just remember there are only 2 areas in the country, ourselves in multiple ways, we received primary care capital allocations and no allocations after we've seen since. We got double what Norfolk got as well. So we are uniquely privileged in terms of getting this capital in South Yorkshire. So it's just really heartening to see we're actually going to get full benefit from it. So thank you.
the other thing I would say is this is a huge capital allocation from the centre to primary care. How can I put it delicately? You don't say no. This is an amazing opportunity for Sheffield. There will be cities outside of Sheffield looking at this enviously. We've been wanting to do this kind of thing for years. We should. Was that Richard? Sorry.
Thank you, Chris. Like Chris, I remember the start of the programme, so it's good to see that
you know, we're now essentially at the end. There was a couple of points just in there. So the first one really relates to what the future offer may be. The presentation sort of made reference to it's really about transferring A to B, but then there may be some future benefits. And if we're going to do these sort of areas, we already know that these are the populations that use urgent emergency care the most. So I wondered what opportunities there's been around in the future to change or alter the demand for urgent care. And then the second one was just related to the point that's in the case about the pressure, cost pressure that potentially been there, and it talks about value engineering, which is, I think, dealing with what's the known issue, but obviously the unknown issue is related to inflation. And then there's a reference in Richard Barker's letter to the capital's only available for a certain time frame and what happens if it isn't.
Yeah, legal should pick that up.
Certainly. So I was going to make 2 points really in the context of the whole programme of work here. So we have been granted 57 million from the Treasury to do this primary care work, which is a huge plus for South Yorkshire. So a huge tick there. We've also managed to secure environment of that capital money from one financial year to the next. So the previous profiling of this, we had to try and spend 20 million this year, which, to be brutally frank, in terms of mobilising all the projects within the programme, was practically impossible.
Yep.
So we've now managed to rephase that money so that appears in the next 2 financial years, which makes the overall projects within the programme deliverable. So that's a huge tick. I did want to make one point, however, that the 57 million hasn't changed, indexed for building cost inflation. So it's not like the Treasury saying we'll top that money up for the extra cost of cement and steel, which is a real phenomenon at the moment. So it's worth being very open and transparent about well, what's happening with the money then for SAPA 1? Well, the money for SAPA 1 is being redistributed amongst the other projects, because otherwise we'd have to have a conversation as a board about which ones we can't afford to do. So the latest calculation is it's looking like the projects within the whole programme, of which Sheffield are the most material schemes, is broadly equal to 57 million, accounting for all that building cost inflation. So candidly, virtue out of necessity, because we're withdrawing SAPA 1, it makes the rest of the projects in the programme affordable. So we need to say that out loud.
We could not have afforded all of them.
We couldn't have afforded all of the Sheffield schemes. So virtue out of necessity, the fact that that one through consultation hasn't landed quite as well, but means we're abating an affordability challenge. So I think that's where we're at on the capital profiling in the projects.
Really helpful.
The second point I was going to make is a more generalised point, is about we have done some very diligent work here appraising the unchanged state like it's a viable option, because we've had to do it like that. I do think in terms of primary care estate renewal, we would struggle with the ongoing viability of these general practices in areas where it isn't particularly attractive to buy property. There are elements of negative equity. So we've done a very diligent piece of work around what does the local population think, contrasting what they've got at the moment with this future change state. I think as a board, we need to be a bit conscious of these practices might not be able to attract partners into them for the foreseeable future. Therefore, I'm not quite sure as a board, we've got this money. We've done, I think, a very diligent process of consultation around the current state and the change state. I'm not sure whether or not that unchanged state is completely viable, as well as being in receipt of the money, which isn't to negate the work that's been done, which is absolutely appropriate.
But it's realistic, I think.
Just on the first point, what I'd say is in terms of urgent emergency care, so one of the things we're doing this year is a review of holiday demand across Sheffield. So that'll be one key thing. But the other thing is we're looking at the anticipatory care, the frailty model and things like that. So this will provide us the opportunity to do that integrated work that I talked about around using electronic frailty index, looking at physio OT, doing assessments for people, much more assessment in the community as opposed to the hospital. So the building is an opportunity, but actually it's the services. We need to think really creatively about how we can use those flexibly and to deliver new models of care. So we'll be doing both. I think as Lee said, we have got, some issues around attracting, the workforce, but compared to other areas I've worked in, we're not in the same league. So I just think we need to think really creatively and putting services around, debt advice and other things as well to support people to live healthily and happily, really.
I mean, I think that's great. The issue that I raised was twofold, really. One was about having an eye to do that. The second one was that consultation suggested up to 20% of people wouldn't transfer with the practice.
Yeah.
And those practices are all centred around the Northern General in the main. And so what we wouldn't want to do is see a transfer of care to the Northern General at half that value, 10% of the practice list, because that's an awful lot of people.
And as part of our review, we're looking at, we were looking at the whole range of emergency care, including the walking centre and other things. We're not, we have to look at it in its entirety. I think I said that before. So we will be looking at same day access, including access to walking centre and things as part of the review.
There's a part of place telling you.
All I was going to say is it's absolutely the proximity of these practices, these communities to the Northern General and their utilisation of the A&E departments. One of the things that we were talking to our communities about is why they would choose to access that instead of primary care access, and some of the challenges have been obviously one of the things. So we've talked both to our communities but also to Sheffield Teaching Hospitals about what opportunities there are there, and absolutely to manage that concern, that risk that the hospital have about more active. So I think there's certainly a lot more work we need to do, Richard, to actually address some of it.
You want to?
Yeah, so just quickly, and for those patients that do decide that they want to re-register somewhere else, then part of phase 3 will be to support people through that journey, probably by investing in the voluntary community sector, to work with them and making sure there's culturally and appropriate communication.
Shahida.
Yeah, I just wanted to kind of reflect back one thing really. I mean, the areas that we're talking about in the northeast of Sheffield, I mean, we've talked about the estate of the GP practices and what they, they've had no, well, let's face it, they've had no investment for 50 years. But actually those communities haven't had structural investment of this kind for more than 50 years. So on the issue of kind of how we're going to attract workforce into those areas, actually this is an opportunity for us to redirect and reimagine what those communities look like, because we're making a practical economic statement that's saying, look, we are investing in these places and these people. And why wouldn't we want to come and work in this amazing, fantastic, like a building? But part of that is about perception change. But I also think we're doing a bit of a disservice to those communities because there's been huge demographic changes in those areas. We don't always take into account intergenerational changes in those areas. And to top that off, we've got a massive talent drain. 4 out of 5 Black, Asian, minority ethnic young people under the age of 30 in Sheffield leave Sheffield. That's a massive, we can't retain the future workforce because we're not giving them any opportunities, or we're not demonstrating to them that we're invested in their places or stay. So I think we have got an opportunity. I think it's how we present that, and then how do we work on that. I think that's one thing. I think the second thing to say as well is, and I think this is really important, I think as Aston was saying, we've got an opportunity here, not just to have these as a flagship, but to do a process of learning that really takes to heart our ICP strategy about integrated health and care. And what does that actually look, what does the future of health and care look like? And I think there needs to be alongside that, not just an evaluative process, but a process of learning that kind of embeds that in our systems, that says we've got an opportunity to experiment, we've got a blank page, we can do it differently, but are we brave enough to do it differently, notwithstanding, what Lee was saying earlier about the constraints of finances?
I agree, and I think we talked earlier about the massive capital injection we've got here in areas of Sheffield that we are concerned about. There's a message when we start building to that community, I hope, to those communities. But the other thing is, what I don't think we want to do, and you haven't said it, so is replicate what we've got in nice buildings. Nice buildings are good. This is a real chance to think about it differently. I mean, you're right, the proximity to Northern General, out of hours, we really need to think about how can we make it, what's the biggest difference we can make? This is a real opportunity for us. Leslie.
Yeah, I mean, thank you to everybody for the work that's gone into it. Thank you for kind of bearing with us while we put a bit of challenge in just around the Christmas period, because I think it was really important that the new structure understood the work that had gone before, and that we were understanding of it because we're going to be taking it forward. I agree that the consultation work that was done really good. I think from my point of view, the key issues that we wanted to understand more were around access issues, and particularly those access issues that were to do with more vulnerable people in the community who, you know, people have said may be least heard as well. So that remains at the heart for me of what we need to think about moving forward. You can't please all of the people all the time, but you need it to be as good as it can be. What I'm really welcoming in that is the fact that that continued engagement and our plans for that continued engagement are going to be critical around some of the issues that we're already talking about this morning, because actually those communities have some of those solutions, know some of the answers to some of the questions we've got, and we need to work with them. So I'll be really interested to see what that future engagement looks like moving forward, because I think it is a massive opportunity for people in those communities. I think it's brilliant, but we need to make sure that we continue in the way that we've behaved up to now.
Brilliant. That's great. Any other points? Gavin?
Yes, I mean, just to kind of echo Leslie's point, I mean, I guess there'll be opportunities to continue to engage with, I'll use the short-term quippy because the proper name's quite long, but I think that'll be good. I think it's just to say that this, I mean, this is just it's a terrific opportunity, isn't it? I mean, it's an incredible investment in some of our most deprived communities. So I think that's to be absolutely welcome. But I think it's also, I think what I'm hearing from this conversation, it's also a massive opportunity from a transformation perspective. So both in terms of transforming the service model and how that's delivered, but also transforming the relationship between the kind of the services and the community. So I think you know, I think we just want to maximise that opportunity.
Okay, really helpful. Thank you for your work. Genuinely great. Everybody comfortable supporting that business case? Thank you very much. That goes forward. Thank you again for your work, Jackie and Emma. Really helpful. Okay. Sorry? Yeah, I mean, I guess the only other question I've then got is we got questions from the member of the public, which is about the nature of our consultation. Could you just stay, Lucy, just in case I need you? And I guess, you know, what we got described there, particularly by both Lucy and Jackie, was really quite a full consultation process that felt to me about as robust as I've seen. I've got to be honest about that. And that looks to me, Andy, as though it answered the questions that were made. Does that feel, am I overly optimistic, or does that feel right?
No, I think you're absolutely right. We did have a number of questions submitted by Nora Everett, and because it was such a comprehensive presentation and the discussion after it, I think we have largely covered everything that was in those points. I'll pick out two if that's all right.
Please do.
So one point was just about the double counting of people who were involved, because obviously there were more than 5,000 responses. But I think the answer is that we didn't want to put a limit on which people could feedback to which elements of the consultation, so that people weren't excluded or limited. So that's the reason why there will be a small number of double counting, just to make sure that there wasn't that restriction based on other people. And then the second point that Nora would have raised if she was here was probably, did the ICP feel that the working with people and community strategy is still fit for purpose about moving forwards, and I think the answer is that because that is a one-year strategy, we'll be writing out stakeholders and our communities very shortly to ask them to discuss with us how we refresh that strategy in 2023 when it comes up for its kind of one-year renewal. So that process will start in the near future as well.
And I'd also go further and say actually we've learned a lot about our strategies from this work. You know, because actually there's been some really good stuff here that should be influencing how we do the next one. Andy, thank you very much. That is formally the end of the public meeting, because it was only a one agenda item. So thank you very much. Laura, thank you. Lovely to see you. Can I declare the public meeting closed? We'll have a 10-minute gap before we do our informal session on planning. Okay, everybody? Ladies, thank you very much.
Bye.
Relatively quick.
Yes, relatively painless.